Greetings, class. My name is Dr. Derek Lemp, and this is NGR 7769, Patient Safety and Quality Improvement in Healthcare, Admin Feedback, Week 2 discussion. I hope you're getting a clear picture of what patient safety and quality in healthcare means to patients as well as stakeholders. This week started your discussion posting, which your initial responses were due by Thursday, and your responses to at least 2 of your classmates were due by Sunday. It is my hope that during the semester you respond to 2 different classmates each week. You will find that some of you lost points on last week's discussion because, although you answered the chapter and video question, you failed to respond to your classmates. Please make sure you do this to receive full points. I have made the Blackboard correction. As you will see, your discussion grades are out of a possible 5 points. Remember, this is 50% of your total grade. I do not mind you working on discussion board postings ahead of time. In fact, I encourage it to stay ahead and stay organized. I do ask that you do not post these responses to the upcoming week discussion until the Monday at the beginning of the discussion week. This is for that your classmates don't get confused when they see postings on the upcoming week and think they have to respond. In addition, many of you have started posting your Patient Safety Initiative topics in Blackboard. Remember, your Patient Safety Initiative topics must be approved by me. If you need to narrow your topic, then I will correspond to your Blackboard postings. If I say approved topic, you are fine to proceed. You are fine to proceed. These topics must be in Blackboard this week, Sunday, February 1st, by noon. It is also a great place where your peers can see the different patient safety initiatives. I would recommend that you view the Patient Safety Initiative folder located in your homepage. It has a lot of valuable information on potential topics as well as resources. These potential topics in no way limit your Patient Safety Initiative topics. However, if you have any questions on a topic, feel free to email me so we can discuss. The Patient Safety Initiative Voiceover Project is due on March 2nd in your Blackboard shell. As you begin to read the chapters in Error Reduction in Healthcare, a system approach to improve patient safety, I want you to analyze your practice setting and your past experience and translate this into your post. As Dr. graduate students, I am looking for you to analyze and formulate a strategic plan on how you can be a patient safety and advocate to quality. This is a learning process, and I understand this. Regarding questions, there is no need to rewrite the questions in your post from the back of the chapter. Just place the correct number to the corresponding question. Chapter 1 questions. Describe the expectation of perfection among healthcare practitioners can undermine patient safety efforts. Healthcare providers often have the unrealistic expectation that they have to be perfect. However, as we have learned over the last 15 years from the Institution of Medicine to Arias Human Report, that humans do make mistakes, and that the first thing that healthcare providers must acknowledge is that mistakes do happen. In fact, this unrealistic standard or goal of perfection gives the illusion that when medical mistakes occur, as they often will do, the person involved in these mistakes are careless, incompetent, and thoughtless. Well, in fact, this creates a second victim effect to providers, and it undermines any safety effort or culture that is to be established. As we now have a better vision and understanding of what Dr. Lucian Leap stated, that mistakes are generally the outcome of a chain of events set in motion by faulty system designs that either induce errors or make them difficult to detect. As we think about what Dr. Lucian Leap has just stated, we can apply that to several discussions that we will have this semester, but especially in this week's discussion. Question number 2. Describe 3 systems or tasks redesigns that will decrease the possibility of mistakes caused by latent failures. First, we understand what latent failure is. Latent failure is, potential mistakes waiting to occur. And there's actually 5 that is discussed in your book. Those 5 are reducing reliance on memory, improving information access, mistake-proofing processes, standardizing tasks, and reducing number of handoffs. Now let's talk about these further. Reducing reliance on memory, utilizing checklists, utilizing computer memory aids, improving information access. This is quite simply having information at our fingertips, our smartphones or computers. When we do computerized charting, having information on educating our patient at our fingertips improves patient safety. Mistake-proofing processes. No longer having look-alike medication. Having systems in place where it is difficult, having a force function where you cannot enter a lethal dose of a medication. The computer won't allow you to. So whoever is translating that or receiving that will not get the incorrect and give the patient the incorrect medication. Standardizing tasks. Making sure the tasks are standardized every single time. Doing it the same way every single time decreases mistakes. Reducing number of handoffs. In healthcare, we often work different shifts and that we often have different handoffs. Research has shown that we can reduce the number of handoffs when we can have better outcomes with our patients. Question 3. Explain why a culture that punishes people for mistakes contributes to an unsafe culture. Quite simply, research has shown that in punitive safety culture, practitioners seek to conceal, to hide their mistakes, and to try to shift the blame. And this in no way creates a culture of sharing. This type of culture, in fact, leads to more errors occurring. So, creating a culture that is one of an advocate for patient safety should be a learned, non-punitive culture. As we learn, as we have dissected these chapters, we understand why mistakes happen. Mistakes don't happen because of humans. Mistakes happen and occur because of faulty systems. Chapter 2, question number 1. Describe the difference between complex technical systems and complex social technical systems. How do these systems affect improving strategies? Well, let's first define complex technical systems. These systems are often automated. These are high reliable organizations such as nuclear power plant, air, railroad are great examples of that. First is the complex social technical system. These involve people. People are responsible for doing this work. This is where healthcare is at. This is where providers are at the sharp end, because we're the ones that are responsible for in this unreliable organization. Now, advocates have seen that the advancement in this the complex technical system has translated. They have the high reliability organizations such as the airplanes and the railroad and nuclear power plants can be translated to healthcare. The checklists that airplane pilots often do before they continue to check their plane and fly can be translated to healthcare. These checklists can be memory aids to help decrease reliance on memory. It's just one example. Question 2. What type of errors, skill-based, rule-based, and knowledge-based contribute to the events to describe in Chapter 1? In Chapter 1 events, the SRK model, basically all of the SRK contribute to the scenario. That SRK is skill-based, rule-based, and knowledge-based. The events in Chapter 1 that led to the wrong site surgery involving Mr. Murphy and Mrs. Jenkins. The skill-based is basically a slip or lapse. You intend to do the right thing, but the execution is wrong. Now the rule-based, the intention is wrong because the operator applied a wrong rule. And knowledge-based, basically you couldn't pull from any knowledge that you had. You had no past experiences. Now, as we saw in this scenario, all of these were present, whereas the slip were utilizing they depended on their memory to try to determine the difference between Mr. Jenkins and Mr. Murphy, or having the PA not assess the patient before surgery, or a number of factors of getting the wrong name on the wrong chart. So it was a whole bunch of lapses that led to this active error occurring. Question 3. Describe the difference between active errors and latent failure. Give a sample of each. Well, basically, a latent error is something that's waits to happen. It's that Swiss cheese model where they're not in a line yet. But, active error is when the error actually occurs. So it's something waiting to happen. It's a faulty system that has not been uncovered as of yet. Where the active error is when the medication error occurred. The patient fell because of everything aligned in the trajectory, and now the error has occurred. Looking at our video of the woman falling, there's 3 questions that we in our discussion. What were the factors that led to the woman falling? Well, basically, there's a number of factors. One of those being the open hatch in the middle of the store. Lack of communication of the person that opened the hatch that went right by the lady. And these were latent errors. It was a faulty system. Having a hatch in the middle of the floor is a faulty system. Number 2, how could this fall have been prevented? Communication. Having someone stand by the opening. Having a barrier around the opening. Not doing this during a busy time when customers are present. Or not having it there at all. And so, having it somewhere away from the heavy flow of traffic. Was this a system error or human error? As we heard from Dr. Lucien, that this was definitely a faulty design system in which a chain of events led to a human error or human accident. And as we get a deeper understanding, have a deeper understanding from chapter 2, as you proceed into week 3, understand that why mistakes happen. Thank you.